My name is Ariel Cole. I am a fourth-year medical student at LMU DCOM, and this is Plain and Simplex. This case is about a 26-year-old male with no past medical history who presented to our emergency department with a 4-day history of fever, cough, and sharp, severe chest pain that he described as radiating to his back with any sort of oral intake. 3 days prior, he visited an urgent care clinic where he received Omnicef and omeprazole. He had no symptom resolution. He denied any NSAID use or other over-the-counter medications except for Tylenol, which he says did not help his symptoms. He states the pain is severe, rates it a 10 out of 10, and describes it as tearing and sharp, occurring with swallowing and specifically water intake. He also complained of constant mild ache in his epigastric region. He states this has never happened to him before. He denied any history of recurrent infections. He is married and does not use tobacco, alcohol, or illicit drugs. He was slightly febrile at 100.8, hemodynamically stable, but appeared uncomfortable and in slight distress. His physical exam was only notable for some epigastric tenderness. He had no leukocytosis, elevation in lipase, or troponins. His EKG showed no signs of ischemia. His D-dimer was elevated at 0.72, and a CTA of the chest revealed no acute pathology, pulmonary emboli, or aortic dissection. CT abdomen and pelvis was performed, which only revealed nonspecific retroperitoneal adenopathy. He was negative for SARS-CoV-2 and influenza A and B. Gastroenterology was consulted and EGD was planned for the next morning. Overnight, he remained febrile and had some symptom relief with viscous lidocaine as needed. EGD was performed the following day, which showed circumferential ulcerations in the distal portion of his esophagus, which the gastroenterologist described as appearing to be viral in nature. The patient was started on empiric acyclovir, as well as Protonix and viscous lidocaine as needed. Biopsy results taken from the EGD returned positive for immunostaining towards HSV1 and HSV2. The patient was found to be HIV1 and 2 negative. He was eventually discharged when he could tolerate oral intake and sent home with acyclovir 400 milligrams 3 times a day, Protonix 40 milligrams twice a day, and viscous lidocaine as needed for symptom management. 2 months later, the patient was seen for follow-up with a repeat EGD that showed complete resolution of the ulcerations and no evidence of stricture or Barrett's esophagus. He had experienced complete resolution of his symptoms. This is a rare presentation of esophagitis. Herpes esophagitis rarely occurs in immunocompetent patients, but was seen in this patient that had no history of immunosuppressive medications, recurrent infections in childhood, and was also found to be HIV negative. I liked this case because it reminds us to always keep a broad differential when evaluating patients. Because there are only case reports existing to describe herpes esophagitis in an immunocompetent individual, there are no guidelines for treatment. This condition is exquisitely painful and affects quality of life, and although most case reports describe resolution without treatment, acyclovir has been proposed and demonstrated in case reports to be an effective treatment to shorten a patient's recovery time. There was also hardly any mention in the literature of the severity of pain of this condition, so this case also illustrates the role of viscous lidocaine for symptom management for patients. Thank you.